Yes. A very good evening to all. Today we are here for the third webinar of Ima Ams Karnataka State Branch. We conduct online webinar once a month on the first Wednesday. So today we have chosen this topic of practical importance to all of us. So it's on recent updates in the management of renal calculi. So according to the National Center of Biotechnology information, over 12% of the total population in India suffer from the problem of renal calculi. So maybe it is the sedentary lifestyle, obesity, decreased intake of water, changing dietary habits, which is making more and more people prone for this problem of renal calculi. So today in our webinar, let us know about these renal calculi and what are the recent aspects, modalities of treatment for these. So without much delay, let us start our today's webinar. At the onset, I welcome our President, IMA KSB, Dr. Shiv Kumar B. Lakkol, sir, to the program. We welcome you, sir.
Thank you. Thank you.
I welcome our immediate past President of IMA KSB, Dr. Suresh Kudwa, sir, to the program. We welcome you, sir.
Thank you.
I welcome our Honorary Secretary of IMA KSB, Dr. Karunakar BP, for the program. We welcome you, sir.
Thank you, ma'am. Thank you so much.
I welcome the renowned speaker of today, Dr. H.K. Nagraj, sir, Professor and HOD, Urology, Saptagiri Medical College and Hospital, Bangalore. We wholeheartedly welcome you, sir, on behalf of IMA KSB and IMA AMS. Thank you, sir, for accepting our invitation. I welcome the chairperson of today's program, Dr. G.N. Prabhakar, sir, who also is a professor in general surgery, vice principal of SSMC Tumkur, past vice president of National IMA, immediate past chairman of IMA AMS headquarters, and presently director of IMA Aken Sinha Institute. We wholeheartedly welcome you, Prabhakar, sir.
Thank you, madam.
Yes. I welcome all the IMA members from other states who have joined for our webinar. I welcome all the IMA members, the president, secretaries of various branches of IMA who have joined for this program. I welcome the postgraduates who have joined for this program. I welcome one and all. Now I request Dr. Karunakar, sir, Honorary Secretary, IMA KSB, to deliver the IMA prayer.
Thank you, madam. Good evening, everybody. An honor to really
Karnakar, sir, your network is poor. Karnakar, sir.
Prayer, time prayer. I'd like to go ahead with that. Bharatiya Agirali. Hello. That's the reason why I have not really put on the video actually.
Okay,
so I'm restarting.
Yes, sir.
ಸಂಘದ ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಲಿ. ಜೈ ಹಿಂದ್. Thank you so much. It's back to Dr. Gita. Thank you,
Karunakar, sir, for the IMA prayer. Now I request our President IMA KSB, Dr. Shiv Kumar Lakkol, sir, to address the gathering.
Oh, can you hear me, madam?
Yes, sir.
Good evening to all.
Yes, sir.
Today is IMA KSB AMS third webinar. Very important topic. The recent update in the management of renal calculus. Dr. Karunakar, Honorary Secretary of IMA KSB, President-elect Srinivasa, and past President of IMA KSB, Suresh Kudwa, sir, and also the past President and also Aken Sinha Director of Headquarters, Dr. G.N. Prabhakar, and our Treasurer, Vijay Sarathi, and also the Chairman of the AMS, Geeta Dappa Madam, and also Secretary Suresh Kagalkar, and all the esteemed members of IMA KSB. Today we are having a renowned speaker, Dr. H.K. Nagaraj, the professor and head of the Department of Saptagiri Medical College, Bangalore, and chaired by our well-known past president of IMA KSB and present director of AK Sinha, Dr. J.N. Prabhakar. So I welcome all for this very good topic webinar. So I don't want to take much time. I hand over this to our chairperson, Dr. Geeta Tappan. Thank you.
Yes. Thank you, sir. Yeah, I welcome Dr. Rajshekhar Ballari, sir, who was also a past IMA AMS chairman and past IMA KSB president to this program. We welcome you, Rajshekhar, sir. Now, I request Dr. Suresh Kagalkar, Honorary Secretary of IMA AMS, to introduce the chairperson of today, Dr. G.N. Prabhakar, sir.
Good evening, everyone. Today is an important day because the two most important person here they are with us. One is Dr. Prabhakar GN, who is a well-known person, started from the Karnataka all over the country, and also is a headquarters person. So, and also there is one more person, Dr. H.K. Nagaraj, who is also a renowned urologist and also famous in the Karnataka as well as all over the country. With this introduction, I introduce the today chairperson, Dr. Prabhakar GN. There is no word to tell Dr. Prabhakar GN, who is the senior-most the person in the IMA. Every branch of the IMA he knows very well. And sir is a professor in the Department of Surgery in the SS Medical College, Tumkur, and he is a well-known personality. And he has got he has held many positions in the IMA. He was a past president of the IMA KSB. He was a past national vice president of the IMA. He was a past HPI director, and he was a past chairman of the IMA AMS. And presently, he is a vice principal of SS Medical College, Tumkur, and also he is presently a director of AK Sinha Institute of Headquarters, IMA Delhi. So, with this brief introduction, I call upon Dr. Prabhakar GN sir and kindly introduce the speaker and continue the session, which is an important topic because super specialty subject which we wanted to take in the IMA AMS. So I requested Dr. H.K. Nagaraj sir, who thank you for accepting our invitation, Dr. H.K. Nagaraj sir. With his busy schedule, he is about preparing to the IMA, this USI Delhi. He has held many positions in the USI. So thank you for accepting once again, sir. I'm hand over the mic to Dr. Prabhakar sir to continue the session. Thank you, sir. Prabhakar sir.
Thank you, Suresh, for the nice introduction. Actually, it's a really great pleasure to introduce our, I can say, I cannot say friend because he's much senior to me, but he is like our friend only. So, Dr. H.K. Nagaraj, he doesn't require much introduction because he's a well-known figure all over Karnataka. So, respected President Lakol sir and Secretary Dr. Karnakar and immediate past President Kudwa sir and the IMA AMS Chairman Geeta Madam and Secretary Kagalkar. Actually, IMA AMS really you're doing wonderful job and you have taken already it's a third webinar you're conducting in your positions. So really, and your last two talks also very good, and you have chosen good topic in the urology. So especially the common problem. So these renal stones, there are actually it is every day it is a new type of treatment because when we were general surgeons during PG days, it was only open surgery. Even in our early practice, we used to do the open prostatectomy and open even the lithotomies and all. So it is now there are no scar, so only endoscopic this thing, and of course PCNL. There are so many things have come. So it is really interesting to hear from Nagaraj sir because he is a very well-known urologist in the especially the southern part of Karnataka. So Dr. H.K. Nagaraj, he looks very young, but and he did his MBBS and MS from Bangalore Medical College and MCH from the Kasturba Medical College, Manipal. And he is a life member of Indian Medical Association and ASI, that is Surgery, Urology Society of India, life member of Urological City Chapter, and a member International College of Surgeons of India, member Kerala Urological Association, member Karnataka Urological Association, member Association of Southern Urologists. So that shows that what is the commitment for the association, because he's member for so many things. And he has constantly supported Indian Medical Association, especially by sponsoring advertisement in the Focus from, I think from 2000, from the year 2000, he has almost given the sponsorship. Thank you, sir, for that sponsorship. And he has served many academic organizations, and also he is awarded. He has awarded for the gold medalist in ENT competition exam, best scientific paper awards. There are many scientific awards, not only in India, even in the US. Also, he has got the best paper award, and in Kerala, he has got the award, best paper award in Urological Association, and best scientific paper award in Bangalore Surgical Society. And he has also organized the annual conference of Urological Society of India in Bangalore itself. And he has gold medal for the outstanding research in urology also, and gold medal for the outstanding scientific paper in the urology in Bangalore, this thing also. And he has awarded Aryabhatta Award in the year 2003, and is also a Kannada Rajyotsava Award in the year 2007. And he has delivered several guest lectures, and also is the Scroll of Honor, Surgical Society Bangalore, and he has received the Doctor's Day Award from IMA Bangalore, and Teachers Day Award from MGR University Chennai, and also he has awarded for Nada Prabhu Kempegowda Award in the year 2016. And many social services he has done. He has served through the IMA, through Red Cross, and he has conducted several health camps, and he has conducted even not only urology, even the cataract surgery, this thing and all, and he is a philanthropist also. So presently, I mean, he has served long in the MS Ramaya Medical College. Presently, he is in Saptagiri Medical College. I wish the best health for him, and to give more strength to serve much more years to H.K. Nagaraj. Thank you, sir. Thank you for accepting
Thank you.
this. And
Thank you.
over to you, sir.
Shall I share my slides?
Yeah. Yes, sir.
Thank you, Prabhakar. Good evening, the program chairman, Dr. Prabhakar, the president, IMAK Karnataka State Branch, Dr. Shivkumar B. Lakol, honorary secretary, and my very good friend, Dr. Karnakar, chairperson, IMAK, KSB, and AMS, Dr. Geeta, my good friend and secretary, Dr. Suresh Kagalkar. I'm indeed thankful to the IMA, KSB, and AMS for giving this opportunity to share this knowledge with all of you. You all know that in the doctor's practice, abdominal pain is a commonest cause, like cough and cold, like fever, how we see, like a viral fever. So those days were there where any abdominal pain means we thought it is due to food infection, but it is also due to stones, maybe in the kidney and or in the ureter. Unless we do investigations, it is very difficult to know, to differentiate what is what. So as a general practitioner, it is very easy if you do just one urine routine examination and do one ultrasound scanning, which is quite commonly available nowadays. Those were the days where labs were not that common. So now, next to any clinic, the labs will be there. If you find a lot of RBCs in the urine, if you find an ultrasound scan, a stone detected, or some indirect evidence that there is some swelling of the kidney, hydronephrosis, then you may be right in thinking that patient is having a stone somewhere in the kidney or in the ureter. So you can give a symptomatic treatment and then say refer to a specialist on this matter. If both the things are normal, then you suspect that there may be some food infection and you can treat symptomatically. Now, what are the causes of stone formation you should know? One is hereditary. So even though it is not that common, so these are the common causes like renal tubular acidosis, especially distal renal tubular acidosis. It is an autosomal recessive disorder, and where there will be the patient will have the acidosis because hydrogen ions are not coming out in the urine much. So there is a lot of hydrogen ions which are accumulated in the body. Patient will have acidosis. So there will be a lot of calcium mobilization from the bones and they develop stones. Cystinuria. Cystine is an insoluble amino acid. If it comes out in the urine, it gets crystallized and forms stones. Primary hyperoxalosis, it usually due to the defective enzymes in the liver, where the glycine is not metabolized properly. So a lot of oxalates will come out in the urine. And majority of these primary hyperoxalosis patients will present to us very early and they develop renal failure. So when the treatment is almost like kidney transplantation and liver transplantation. So that is the situation in these cases. Other causes, geographic and climate. When you food habits, suppose we go to some countries where they eat a lot of the meat, where high purine content will be there, and also temperatures. If you think of in the Bangalore surrounding areas, if you go to a Kolar district, the stone incidence is very high. Or if you go to north of Karnataka, the stone incidence is high, comparing to the Bangalore urban per se, because of the high temperatures. So a lot of sweating will be there. They will be working in the fields. They may not have much time to drink water. They may not be carrying a good a potable water with them. So these are all the common causes of stone formations. Coming to the age and sex, commonly we see between 3rd and 5th decade, but it is, we have seen in children also. I've treated a 1-year-old child with a stone, which is surprising to us also, but commonly it is seen between 3rd and 5th decade. And it is common in males. The reason they have given is the estrogen which is produced in the body is going to increase the citrate levels of urine in the urine. Citrate levels will be high in the urine. So that's why there is some restriction in the formation of stones in the females. Coming to the water intake, you people will ask how much water I have to drink. So we usually say that the patient should pass at least about 3 liters of urine. So it's not necessary for all the people to drink water. Only those who have formed stones, if they come first time or second time, that type of patients, you tell them to drink more water. Otherwise, it's not necessary a common man drinking a lot of water. What is sufficient for him, whatever he feels like drinking, the tongue is the better indicator of how much water he has to drink. So that is sufficient. Otherwise, if you ask everybody to drink 3 to 4 liters of water, so they have to go very frequently to pass urine. So they will be working in the offices. It's going to be hamper their regular work, day-to-day work. And you should also know that the mineral content of this water, what they drink. Now, fortunately, many cities and the villages, the good water is there, filtered water is available. Those were the days where from the bore wells they drink water directly. As we go deep and deep, we know that the mineral content of the water will be very high, especially the borewell water. Comparing to a open well water, the borewell water, the mineral content is very high. So the patient will ask us, how do I find out my water is safe or not? I'm drinking from the borewell. Okay, the simple method which I tell them is, you collect 2 liters of water, what you are drinking, boil the water for 1 hour, cool it till next day morning, check how much is the salt sediments are there in the bottom. If there is a lot of sediments are there, that means he has got a lot of calcium carbonate in the water. So it leads to stone formation. So this is the simple methods where the patient himself can check it. Diet, which I already mentioned, excessive consumption of non-vegetarian products, excessive consumption of milk products like Punjab. If you go to North India, the stone incidence is very high. That is because they drink a lot of milk products, a lot of milk they take, curds they take. So that may be one of the, and the temperatures are high. That may be one of the reasons. Occasionally, we have seen some patients taking a lot of calcium tablets. Somebody had prescribed it, so they keep on taking for years together. That is also one of the reasons. So we should check in the urinary calcium levels in these patients. If the urinary calcium level is more than 400 milligrams in 24 hours, that means that they have to cut down it, and also check the serum calcium levels. If it is there on the higher side, about 10, ask them to stop it, not necessary to take as a routine. The other, which is also a very important cause, immobilization. Suppose the patient has got a paraplegia, he is lying down in the bed. When there is immobilization, there is a lot of mobilization of calcium from the body, from the bones, and they come out in the urine. So that produces stone formation. And most of these patients also will have a catheter in situ. That's why urologists will never recommend a continuous catheter drainage for any patient who requires a continuous catheter drainage. We always tell the attendants, 1 week drainage is okay. If the patient requires catheter drainage more than 1 week, they have to go for self-intermittent catheterization. If the patient cannot do catheterization and remove the urine, we train the family members to do it, so that the stone formation, infection formations will be very, very less. Urinary stagnation, we all know that benign enlargement of the prostate, the commonest cause of urinary retention in males, and they neglect it. So they can form stone because there is a lot of sediments in the urine which gets deposited and form stones. And sometimes we have seen hydronephrosis, congenital hydronephrosis, multiple stones in the kidneys we have seen. And then in females, old age, they will have a urethral stenosis. That again, chronic retentions, and we have seen this. Chemotherapy, there is a lot of mobilization of calcium of the bones, demineralization occurs, so they can form stones. Calcium tablets I already mentioned. Urinary infections again is a commonest cause of infection, stone formation in the kidneys. We call it struvite stones, which is you treat it, you remove the stone, within 6 months you see same type size of stone as if we have not operated at all. So the urologists, we should be always beware of this. It is usually due to the Klebsiella protease group of bacteria. So we have to monitor the urinary cultures very frequently. When I come into the urine culture, I have one common mistake which I see in all the doctors. If a male patient is giving urine for culture, he has to pull the prepuce back and give the urine sample. If he doesn't pull the prepuce back, neither a doctor nor the lab technician explains this simple precautionary measure. So the urine, when it touches the skin and comes out, it shows infection, bacteria. So they keep on treating. There is infection, you take this in. There is infection, you take this treatment. So we have seen this very, very commonly. And I request all the doctors through this forum that if you are asking for a urine culture, the lab guys are not explaining it. The doctor should explain that pull the prepuce back, pass little bit of urine and collect only 5 ml or 10 ml and give the sample. In females, they have to sit, separate the labia, pass urine, and tell them that as far as possible, it should not touch the skin and the urine should come out. Leave a little amount of urine. So why I'm stressing is, I've seen many patients, especially newly married couple, the female getting infection, the doctor treats it, asks for a culture, and then culture is positive again antibiotic, telling the lady not to become pregnant till the urine infection settles down. And it went on for 1.5 years. So they were frustrated. When they came to me, I said, no, I will collect the sample. The problem is that you are not giving a proper sample. So when I, after proper cleaning, I put an infant feeding tube, collected the sample and gave it, it became sterile. Then I told them that you go ahead with pregnancy. So we have seen these problems happening. So hyperparathyroidism, which is not that common, but it can produce stones because there is a lot of calcium mobilization from the bones. So they will have stone formations. So these are all the various things we look for when the patient comes with stones. What is the cause we look for? But majority of the times, almost 70 to 80% of the times, we don't find the cause. I can say that we still don't know what is the cause for the stone formation. Many patients, we still don't know. So I try to do, now we are doing a study after I joined Saptagiri Medical College, after my retirement from Ramaya Medical College. So we are analyzing all the patients who have got stones with blood investigations and urinary investigation, 24 hours urinary things. Once I told them, our postgraduates, once you complete 100 cases, you analyze and let me know whether we are missing out anything, how we can go ahead and advise these patients. Because the important question they ask is, am I going to get the stone again? At present, the answer is yes, he's going to get it. And then the next question will ask you, how do you prevent it? We have no answer. I tell them to drink a lot of water. He says, sir, I am drinking 4 liters every day. Still I am getting stones. And then you don't take non-vegetarian. If you say, sir, I am a pure vegetarian, sir. Then, so where is the answer for us? So we have to do some study on these things. Now coming to the types of stones, commonly we see calcium oxalate and calcium phosphate stones. These are the commonest stones we see. Occasionally in about 5% of the population, we see uric acid stones, especially those who take a lot of the non-vegetarian food. The uric acid levels will be very high. So we do see. Cystine stones are not commonly seen. It is commonly seen in the West. Fortunately, we don't see much. Triple phosphate, what I told, infection stone, which is also called Stewart stone, it is also seen in India. Xanthine and indinavir. You know that indinavir, we use it for the retrovirus cases, positive cases. So that can come out in the urinary system, gets deposited and form a stone. There are various theories of stone formation. See, whenever we don't know the cause for stone formation, all the theories comes. Wherever the medicine, when there is don't know the cause, so many theories we postulate it. Maybe this, maybe that. So this is the supersaturation theory. Some people say because there are inhibitor lacking is there, inhibitors are less. And some people say matrix, there is a material which produced in the kidney, which promotes the stone formation, and a combination of all. So what are the inhibitors of crystallization in the urine? We call it organic inhibitors. They are peptide, alanine, citrate, and urea. Citrate is the most common thing which any deficiency, they can form stones. The inhibitors of crystallization, inorganic inhibitors are zinc, pyrophosphate, and magnesium. Magnesium is very important because it combines with the oxalates, forms magnesium oxalate, which is more soluble in the urine than calcium oxalate crystals. Okay, Now coming to the symptoms, it may be a renal or ureteric colic. We should be able to differentiate between what is renal colic or ureteric colic. Renal colic is a fixed pain in the loin. The patient will be holding the loin and he says it's paining here only. There is no radiating at all. A ureteric colic usually will be radiating. So sometimes in males it will be radiating to the testis, radiating to the penis. We have seen in radiating to the thigh. In females, radiating to the vaginal area. We see, and then occasionally some patients complain of hematuria. It is not a massive hematuria, but they say that the blood staining is there, some blackish coffee color I passed. They say occasionally we do see fever. Fever is not a common symptom, but we do see nausea, vomiting again is a common symptom. So we should be careful. We cannot give tablets when a patient is having nausea, vomiting. We have to go for an injectable form only. And many times we have seen silent stones, which has gone in for kidney failures. We have seen this also. So beware, it's very difficult unless you do every year an ultrasound scan. So some these things might be missed out. Coming to the investigations, urine routine examination will give you a lot of information. So WBCs will be high when there is a stone because of the inflammation. It is not necessarily due to infection. So you should be aware of this. What is infection? What is inflammation? We have seen the doctors giving antibiotics because the WBCs are high. That doesn't mean that high WBCs means there is infection. Unless you do a culture and confirm it, till that time, if you want to give antibiotic, give it for 2 days, or 2 or 3 days. Once the culture comes, then you treat accordingly. Otherwise, don't give empirically antibiotics only looking at the WBCs. RBCs, you may or you may not see. If you see RBCs, it is almost to say that maybe a stone somewhere cause of the pain to the patient. Sometimes we do see crystals which are very pathognomic and diagnostic. If you see some cystine stone patients will have a envelope type crystals, coffin lid in struvite stones. This, if you see, it is pathognomic that patient is suffering from stone disease. Blood investigations, commonly we ask for blood urea creatinine because most of the people use the NSAIDs. So we should be diclofenac injections, which is a very good drug. Unfortunately, it can be produce renal damage. So you should be, before you put diclofenac, either an injection or a suppository or orally, you see that creatinine is checked. Till that time, you use other painkillers, paracetamol, or you can give IV also. You can give orally if the patient tolerates it. Till you get the creatinine value, then you can start. Now, to diagnose this, commonly we do ultrasound scan, a KEB X-ray, intravenous urogram, and a spiral CT. Most of the times nowadays we do an ultrasound scan, and rarely we do KEB X-ray and intravenous urogram because now CTs are rampantly available everywhere. Most of the times plain CT is enough, not necessary to do a contrast enhanced CT scan. Plain CT will tell where is the stone, what is the size of the stone, what is the Hounsfield unit of the stone. So this is enough for us. Very rarely we require, if the stone is too big, if we want to go for intervention, then we have to do a contrast enhanced. But before we do contrast enhanced CT, we have to go for a serum creatinine. If it is normal limits, then only they also do CECT. In ultrasound scan, the indirect evidences are calyceal dilatation will be there, ureteric dilatation they will give. Occasionally they demonstrate a stone, the sonologist, but many times we may not be able to see a stone because of the gas shadows, or if the stone is in the mid-ureter. There is a limitations for this investigation, ultrasound scan, but gives you some clue that patient may be having this. Go ahead and do further investigations. So I told you that IVUs nowadays we don't do it because CT is a very good option and less radiation than intravenous urogram. So I'm not going to talk too much on this. This is one X-ray You see the KEB X-ray, which shows there is a radio opaque shadow here in a KEB X-ray. Just to tell you how fallacious the investigations are. So somebody think that there may be a stone in the ureter, whereas here later on we did a intravenous urogram, which shows the stone is outside the ureter. So there is a radio opaque shadow outside the ureter. It may be a phlebolith or maybe a fecolith. So that's how the one investigation is not going to give all the information. We should be careful. This is one intravenous urogram, which is showing a stone which is obstructing the pelvis. Hydronephrosis is there. The other kidney is okay. So this is one KEB X-ray which is showing a vesicle stone. Maybe patient may be having a prostatic obstruction. This is the CT film which is showing a big stone, radio opaque, radio dense, hyperdense stone in the kidney, and there is one more stone in the upper ureter. So this is CT urogram, which is showing that the stone is obstructing at the pelvic junction, but still the contrast is coming down. So this is all the information we get. Not all the time we need all this investigation. So we should select when you want this CT urogram, when you want plain CT, or when you can go ahead only with ultrasound scan. So this is one more picture showing a big stone, which is about 5 centimeters big stone in the KEB X-ray. Now, coming to the management aspect, painkiller is the mainstay of our treatment. So I agree with you all. The diclofenac is a wonderful drug, but be careful. So if the patient is diabetic, if the patient creatinine you know properly, then only you give it. Patient is diabetic, avoid giving diclofenac. If the patient is hypertensive, avoid giving diclofenac injections or tablets orally. So all this Buscopan, all those things honestly doesn't work in this pain, because you know that after the labor pains, the severest pain is this pain, the renal ureteric colic or a renal colic, stone pain. So that much of severe pain they get. So even paracetamol doesn't work. IV, if we give paracetamol, it doesn't work. So I usually use diclofenac suppository, 100 milligrams suppository, but I check the creatinine and carefully I use it. So that cautiousness should be there when you're using a painkiller, because as soon as a patient comes to you, you have to give some painkiller. So depending on your choice, if you know the patient very well, you put a diclofenac suppository. Within 10 minutes, the patient pain goes, the vomiting goes, patient will be much relieved. Then you get the investigations. So without giving pain relief, if you start investigating, no patient likes it. He will walk away to the other doctor. So that's the thing. Very rarely we use antibiotics. Occasionally we use if you think that patient is having fever, otherwise not necessary. Antiemetics is very important because they will have vomiting. So we have to use antiemetics. And then, the common practice, what we have seen is giving IV fluids. I agree, you give IV fluids, start an IV fluid, because many of the patients will have nausea, vomiting, so they're exhausted. You will have to give IV fluids, but don't rush too much of IV fluids, because the stone is obstructing the ureter. The stone is obstructing the kidney. So the patient is getting pain because the stagnation of urine in the kidney. The renal capsule gets stretched. So if you give more fluids, the patient will have more pain. So don't do that. Whatever is possible to reduce this tiredness, exhaustion, you give limited fluids, relieve the pain. And then there is no scope for forced diuresis. What we are practicing earlier, giving 3 to 4, 2 liters of water, IV fluids, then giving Lasix. Don't do that. It is very dangerous. If you do that, the calyces will get ruptured in the kidney, and the urine comes out. We have seen all around the kidney urine coming out, or urine coming into the abdominal cavity because of this injury, rupture. So don't force fluids. And don't give forced diuresis. Let it be, if you think that the stone is small, I'm going to come to that. If the stone is less than 5 millimeters, the chances of stone formation are very high. Usually 3, 4, 5, and sometimes 6 millimeters also. We go for a medical line of management. Tell the patient, you will get pain. There is no delivery occurs in this world without pain. Like that, when the stone has to get delivered, you will get pain. So try to convince the patient. Otherwise, you will go to some other doctor. Try. If the patient is very distressful, admit him, then you take care. You can go for, even though it is 5 mm, we have seen patients having a lot of discomfort. Nowadays, majority of the patients are in very good positions, working, earning a lot of money and all. They say that, sorry, doctor, I have to go back to my work. You have to help me out. So then we go for a not conservative, some other management, like already mentioned, lithotripsy, PCNL, lap surgery, open surgery, robotic surgery now has come. So these are the things now we adapt. I'm going to show one by one when we choose all these things. So this is one lithotripsy, where you can break the stone by using sound waves. No pain to the patient, no anesthesia is given. Very rarely we admit a patient. So, patient, it takes about 1 hour. So we can monitor on the TV how the stone is breaking. This is one option. Now, this we do it if the stone is less than 20 millimeters. That is the reason is, when the stone breaks, a lot of fragments will be coming down the ureter. So patient should not have vomiting, fever. So to avoid that, we limit 20 millimeters, and then ounce field units. If it is less than 1000 ounce field units, then we prefer. More than 1000 ounce field units, the fragmentation is slow, and then it may not break also. That's why that options are there. We keep it. Suppose some patients are there. We have got a 30 mm stone, like this patient here. He has got a big stone, and his ejection fraction, cardiac ejection fraction is 35. So we cannot do surgeries in this type of patients. Even if I am pushing for a surgery, that surgeons are always, we try to push for surgeries, but anesthetists will say no, we cannot give anesthesia. So this type of patients, we put a double J stent so that the fragments doesn't come and block the ureter, and urine stagnation won't be there. Then we do lithotripsy. So this is also an option is there. This is how the patient passes the stone fragments in the urine, and immediately after blasting, we tell the patient to pass urine into a tea stainer so that he can see the stones coming out in the urine. He is also happy, we are also happy. And the cost also comes down. When you go for a lithotripsy, unlike other open techniques or endoscopic techniques, the cost will come down to the patient. Now, when do we do percutaneous nephrolithotomy? That is, we make a small hole into the kidney and remove this big stone. When there is a severe obstruction to the kidney, when the stone is more than 25 millimeters, then when there is infection stone, we cannot do lithotripsy. When there is infection stone, and then a cystine stone, it is a very hard stone, it doesn't break. Fortunately, we don't see that commonly. So these are the indications for that. The technique is, suppose now I am showing, see there are so many stones, 1, 2, 3 stones. So these are the stones where we go for a PCNL. That is, we make a small opening into the kidney, and then you see that it is severely obstructed kidney here, a stone is there. So this lithotripsy, we rarely do it. This is again one stone, we are showing a very big stone. So this type of stones, we puncture the kidney. This requires anesthesia, admission for 3 to 4 days, and then blast it. So this is how we do it. This is a big stone patient has got. So we first pass a ureteric catheter. We inject contrast into that. We dilate the tract. I'm going to show later on. And then we pass guide wires like this down the ureter. Then we dilate the tract and see the locate the stone. So this is how the ureteric catheter is passed. These are the stones we see. This. Then we inject contrast to delineate the system. See, this is how we make a puncture into the kidney. A small puncture is made, we pass a guide wire. So that tract is dilated. So we see urine coming out, we pass a guide wire is going in, and then we dilate the tract to about 25 to 30 French it goes. Then we pass this ample sheath, we call it, so that the scope can go in and out frequently without losing the tract. So this is the end result. A small opening about maybe about 1 inch, and one tube will be there. So that's all the treatment, PCNL. So the stones are picked up like this, multiple stones. So this is the end result, the final scar. This is a small scar. Earlier, we used to put a long incision of 16 to 18 centimeters long incisions. So that we don't do nowadays. 99% we can remove with these techniques only. There are some indications for open. I'll come to that later on. So this is how we see stones inside. And this is how graspers are there picking up the stone. Then we put a nephrostomy here for 48 hours. Then remove the nephrostomy, patient is going home. So this is one patient, you see that a big stone is there. Big stone. So I'll fast forward it. You see that dilating the tract. This is one of the technique which was long back, maybe in 2001 or so, which I popularized, sitting and doing a PCNL. I think Suresh will agree that all PCNLs are done in standing, right, Suresh? So this is one technique where you can sit and do the surgery. And the advantage of this is when you are breaking the stone, lot of stones will come out by gravity. So this is quoted at many centers. See, we have gone inside, we are seeing the gold mine of stones inside. So we break the stone, such big stones, we keep on breaking it. So most of it stone will, 30 to 40% of the stone fragments will come out by gravity itself. We need not pick up. This is one of the commonest operation done by many urologists. Stone is breaking. I'm just going to show. See that so many pieces we took it out, and this is the final result. I showed you that so many pieces are inside, down. Without me picking up, so many stone pieces came out. So that type of huge stones, which is about 7 centimeters, we would have done an open surgery, but we could. To the system, we cannot do PCNL, so we have to do it. If the stone
Sir, please unmute yourself, sir.
So
Hello, doctor.
then we do that. Can you hear me?
Yeah, yes, sir. Please. Sir.
Okay. not going. Okay. These are all the open techniques, standard pyelolithotomy. Nowadays, we very rarely do it. This is the technique how we do it. Extended pyelolithotomy. These are all the very popular techniques more than 20 years back. So not many people do it now. So inotropic nephrolithotomy, again, it is not commonly done it. Occasionally we do it in medical colleges. We have to do some of these gimmicks to show to the postgraduates to learn the techniques when they're in the far places where the facilities are not there. They have to know how to do inotropic nephrolithotomy. Otherwise, I'm not a proponent of open surgeries. So this is how the kidney is opened and the kidney is sutured back. So this is how the kidney is open, exposed. We put ice and then clamp the renal artery, renal vein, then cut open the kidney and remove so many stones which you are removed. I might have done about 5 or 6 in my almost 35 years experience. This is one interesting thing where an ectopic kidney had a stone disease. So it is very difficult to do PCNL in ectopic kidney. So in such situations, we can use this laparoscopic mobilization and then remove all the stones. He had about 8 stones, which we did it laparoscopically, removed all the stones, sutured it. So it's a minimally invasive technique where the patient goes home with days with this technique. I try to fast forward. Then we put a stent and then close the opening there. So we're putting in the bag and removing the bag. Okay, that's it. We'll go to the next. This is now the new technology which has come, robot. So, okay. So this patient had 38 stones, and he also had a congenital pituitary junction obstruction. He's a software engineer, for 32-year-old boy. So we did it through robot. It can be done through laparoscopy also, but he was asking for that. Can you do it through robotically? The common man thinks that robot, if you do it, the results are better. Maybe good for some surgeries, not all for all surgeries. But he has to pay another 1 lakh extra if I do it, use a robot. So we did it through robotically. We removed all the stones. The great advantage of robot is the tremors are not there. And see, it's precise. You go in, what you catch will be precise. There is no more adventitious movements are not there. Okay. Okay, coming to the removal of the kidney. Is there any indication where stone disease, we remove the kidney? We have come across many places where the kidney has been removed because it is non-functioning. But to prove that it is non-functioning, you have to do an isotope scan. Otherwise, by just doing a CT scan, if they say that it is non-functioning, please don't take it. Do an isotope scan, confirm that this kidney is not functioning, and see how is the other kidney. If the other kidney also is weak, Don't remove the kidney as far as possible. Remove the stone and put a stent. Wait for 3 months. See how much is going to respond. We have seen many patients the responding, and the kidney starts functioning. Maybe not much, but 10 to 15% contribution from the other side, from the disease side. So that is good enough. So think twice before you do nephrectomy. This is the message I want to give. And don't go, by the parenchymal thickness. Parenchyma is too thin. Don't remove. Will not do stone removal. Will remove the nephrectomy. Will do the nephrectomy. That's all about the kidney stones. So lithotripsy is an excellent procedure. If the stone size is big, PCNL is the best option. And now flexible scopes have come where they put the scope up to the kidney, take a lot of time, and the cost is still a problem to the patient. So even though we have a flexible scopes, we rarely utilize them. It's only for a postgrad training we use it, rather than as a primary armamentarium. I don't suggest for a kidney stones to go for flexible scopes. Coming to the treatment of ureteric stones, I already mentioned that if the stone size is smaller, 4 to 5 mm, you can go for a watchful expectation, but you have to counsel the patient. Otherwise, you lose the patient. And then shockwave, we routinely practice shockwave lithotripsy. It is a wonderful thing for ureteric stones. Even the lower end of the ureter, probably we were the only center in the state to do a lithotripsy for lower ureteric stones also. Excellent results, no admission, no pain, no anesthesia. Patient morning gets admitted, evening he is going home, and he passes stone pieces and he will show us with a smile, he goes home. What else we want? And the cost is almost 25% of what the other techniques, ureteroscopic basketing, we do. So these are all the various options we have, 4 options. I'm going to show one by one. So this is again, I'm showing you the lithotripsy. Patient is lying down. The therapy head comes from top. And see, it is coming from the top. You can see therapy head here, coming from the top and focusing. We can see on the TV, where is the stone and where is our marker. Fragmented, patient passes in the urine. Next. So ureteroscopy indications. In my practice, because I'm a strong proponent of lithotripsy for anything and everything, so I rarely use it. But in medical college, I have to advise some of the patients to undergo for ureteroscopy, because the postgrads has to be trained in all these techniques. And the stone in the lower ureter or mid ureter, we can do ureteroscopic basketing. Upper ureteric stones, we usually do a lithotripsy, because when you're doing a ureteroscopy, many times the stone goes into the kidney. And then once again, we have to put a flexible scope. So the cost factor is a problem. So this is how the ureteroscopy is done. You see, you can go inside, see the stone, break it either by using a laser or by a pneumatic lithotripter. Pneumatic lithotripter is still, see the stone, pneumatic lithotripter is still the best, but occasionally laser, if you have, it is more the merry. So we are doing fragmenting the stone, and then some people use the flexible scopes to do all these things. We'll go on. Very rarely we put a double J stent, but if there is a trauma to the ureter, there is nothing wrong in putting a double J stent. Okay, I'll go to the next slide. Now coming to the indications for a ureterolithotomy, when we go for an open operation. So there are limited indications. So I'm going to show the one patient where patient had 2 stones in the mid ureter. Can you see 2 stones in the mid ureter? This one was very long. So we did a laparoscopically extraperitoneal approach. We identified the ureter laparoscopically. You see the ureter here. This is the ureter. There are 2 stones. So we incised 1 stone and expelled it out. It can be done extraperitoneal or intraperitoneal, depending on the expertise. So, see the big stone which she had, 2.5 centimeter stone. So there is one more stone which will be down and brought it out through the same hole opening. Then put a stand and close the ureter. I'll go. It doesn't take much time, maybe 45 minutes or 1 hour. We can finish off that. Now, if I already mentioned that the use of the flexible scopes. So in my practice, I feel that the scope is limited. So it is only a fashionable one. Tell the patient that I put a flexible scope, RIRS, I do all those things. But because the cost is a problem. So the minimum we have to charge the patient 75 to 1 lakh extra to the patient, the equipment cost. So my patients are not that affordable. So I rarely do it, but flexible scopes are available, and this is an option where we have to use a laser also. The choice is to the surgeon. Now, if you ask me how you manage uric acid stones, whether we can do a medical line of management to these uric acid stones. So this is some of the medicines can be tried out, because if you alkalinize the urine, many uric acid stones gets dissolved, but it takes time, 1 month or 2 months. So whether the patient is willing to wait so long is the question. So sodium bicarbonate tablets we give to alkalinize the urine, and then in most of these patients, the uric acid will be high, either allopurinol or febustat, the new drug. A lot of fluids we have to give, and then he has to restrict the purine diet, fish, like that. That's all. Thank you very much. I once again thank the Karnataka State Branch and IMA and the AMA for giving this opportunity.
Okay, sir.
Thank you very much.
Hello,
Hello.
Suresh, your voice is not clear.
Prabhakar, sir.
Can you hear me? Hello.
Hello.
Hello. Can you hear me?
Hello,
Hello.
sir.
Do you allow any questions in the chat box?
Yes, sir.
Yes, sir. Yes, sir. Yes, sir. Please.
You can.
Yes, sir. Dr. Veena.
Question.
Yeah.
Yeah, Dr. Nagar, sir. One question. Especially for our members. Hello, sir.
Yeah, good.
Yeah, one question for all our these stones. Sonography has got some stones. So one question to you, sir. When to refer the asymptomatic stones, that is ultrasound showing a stones, either in the ureter or in the kidney. When to refer to you, sir?
Okay.
That is many questions, especially.
You can refer to I work in Saptagiri Medical College, Bangalore. Kindly refer there, because it's one of the cheapest medical college, cheap and best treatment we can opt to give to the patients, and we accept all those Ayushman Bharat cards, so we can help them.
Okay, sir. So when to refer?
I hope you can take. Your secretary will give my number, or I can give them my number. You can take down also. 9341. Yeah, 934122 3797.
Sir, my question is, sir, when
Yeah.
to refer the asymptomatic stones?
Gita, your line is clear. Can you take that question and forward?
Sir, we have a question in the chat box
Yeah,
from
okay.
Dr. Ima Ams Webinar from Bhagravati. What is the cutoff value that stones of 6 millimeter or 8 millimeter for expectant management?
Yeah. See, 6 millimeter stones, yes, you try out the technique, conservative management. So possibilities are there. 8 millimeters, the possibilities are less. So go for some advice, other ways, and refer to the urologist.
What is the hello?
Yes, sir.
What is the line of treatment in case of enlarged prostate? Enlarged prostate.
Okay. See, most of the times nowadays we go for a medical line of management. We have to go see kindly look for PSA values in all these patients, so that if the PSA is more than 4, there may be suspicion of a cancer in the prostate. So that's why kindly look for PSAs, because patients see you more than seeing us. So that is one. And then look for what is the prostate size. If the prostate size is less than 30 grams, you give only alpha blockers. One at bedtime. Alpha blockers. Tamsulosin is there, silodosin is there. At bedtime, 4 milligrams or 8 milligrams you can give. And then if the prostate volume is more than 30 grams, please add dutasteroid also. Combinations are available. You give them, they have to take it at least 2 to 3 years minimum.
2 to 3 years.
Yeah.
Thank you,
Actually,
Dr.
it is
Nagaraj, for
lifelong.
excellent,
The treatment is
excellent
lifelong. But okay.
Thank
Yes.
you.
Thank you.
Thank you, sir. Nagraj, sir, we just
Thank
want
you. I'll cut off.
being an obstetrician, sir, I want to know in pregnancy what will be the difference in the management of these renal stones.
Yeah. See, pregnancy. One caution for the obstetricians is if they come to you before becoming pregnant, a couple, better to do an ultrasound scan to know stones are there or not. You know our difficulty during pregnancy. If there is a stone, we cannot give good painkillers. We cannot do any treatments. Very difficult. And then, but first trimester we cannot do anything, because the chances of this one miscarriage are more.
Yes.
Second trimester, third trimester, sometimes we put a double J stent under local anesthesia and leave it. Let the patient deliver and then come back. And then some patients, third trimester, we do a ureteroscopic removal of the stones. If there is a stone in the ureter, the stone in the kidney, we put a stent and ask the patient to come back. As less as possible invasion we have to do during pregnancies. You agree with me?
Yes, sir. Because it's very difficult for the pain management, sir. Because diclofenac also we can't give frequently, and the patient will be having so much pain. So very difficult to manage these patients.
Now the other thing which I noticed in your practice is because we get patients referred. The patient is 28 weeks pregnant, and patient is getting back pain. So they do an ultrasound scan which shows a 4 mm stone in the kidney. So the gynecologist says, no, you go and meet a urologist. But 4 mm stone rarely produces that much of severe pain. So I keep tell them that it may be due to the expanding uterus, especially to the primis. The pain is due to that uterus being expanding. So go and meet back the obstetrician.
Yes, sir. Like, sir, up to what the stones are asymptomatic in your practice? Like when they start producing symptoms as such?
Anything above 4 millimeters, they keep producing problems.
Okay, sir. Okay.
Up to 4 mm, they can pass out on their own. But anything above 4, they don't come out without producing discomfort to the patient.
Sir, Nagaraj sir.
Yeah.
Yeah, Dr. Prabhakar.
Yeah.
It was a really excellent talk, especially this type of talks, very useful for the postgraduates actually. So it was from the etiology really told in detail what are the causes and what are the clinical features and also the investigation, treatment, everything you have covered. Thank you, sir. So I have one more meeting here. So I'll take a leave. Thank you. Thank you, madam. Thank you
Yes,
very
thank
much.
you, Prabhakar, sir. Thank you very much.
Thank you very much.
Yes,
Okay.
yes, sir. Yes.
Sir, one question, sir.
Yeah.
I have got one question. What message you want to give to the pediatrician for a stone farmer? For a pediatrician, for a stone farmer, what message you want to? Because many times the children, especially less than 5 years, they are having a stone. The parents and attendants are anxious. So repeated formation of.
Unfortunately, repeated stone formation, we don't have the answer, because many times when we investigate, we don't find a cause. But but we have minimally invasive techniques. We have miniatured scopes where we can take care of these children. Miniaturized scopes are available, so no major surgeries can be done. We can do it. We have done ESWL giving anesthesia to these patients. Without operation, the stone will pass out.
Okay, sir. Is there a role of any stone culture so that the stone
we are not doing, we do a urine culture in all cases, stone patients, but stone cultures we have not done. There are some literature on that, but we have not done it. It is not that useful in clinical practice.
Sir. Okay, sir. And very well presentation, sir. It's a vast subject, and you are told in a very effective manner. All the surgeons have got a misconception, especially about the role of effect of doing the H2 scan. So these are things very well told regarding boiling the water. What type of water? People many times the attendants will be asking how much I should take a water, and all the things you are told very clearly, sir. It is a good message to all the members, and it is a very common topic. Any questions, sir?
Not only urologists see the stone patients, more than urologists, it is the other general practitioners, general surgeons, even gynecologists also see more stone cases.
Sir, my one more question left behind. That how when to asymptomatic?
When to
refer asymptomatic. Asymptomatic symptoms are not there.
You see, I always tell the patient it is not like a gallbladder stone. If the gallbladder stone is asymptomatic, we rarely treat. But renal stone, invariably it is going to produce problems. Today or tomorrow, he is going to get pain. So if the stone is more than 6 millimeters, go for some treatment. Most of the times we do ESWL, lithotripsy we do. So no, don't allow the asymptomatic stone to go there only. It will keep growing. We have seen this. I told you some 2 years back, take the treatment, you will be all right. 2 years, COVID was there, sir, I could not come. Afterwards, they have come with a 25 mm stone. It is surprising to me also. When I had seen it was 8 mm, 2 years time, it has become 25 mm. So I don't think we have to delay. The pain is not there.
Yes, sir. So we have one more question from Dr. Veena and from Sulya. When to remove the stent?
See, we in our practice, in my practice, I rarely put a DJ stent. The apprehension is, we put a stent, we tell the patient that there is a stent, you come back, and then we also underline in the discharge summary, still patients rarely come. They come after 1 year. By the time there will be a lot of encrustation. Usually we remove the stents on the 15th day. Our maximum is 1 month, not more than 1 month. So, but patients forget, and because we are in a medical college, we have postgraduates working with us. We caution them. They have to call the patient after 15 days. Call back and remove the stent.
Yes, even after ureteric lithotripsy, sir. After any procedure. Yes.
Yeah. 15
Yes.
days is enough.
Okay. Sir.
10 days.
I
I'll
think now,
sign
yes.
off.
Yes, sir. So just one
Thank you.
formal vote of thanks in the end, sir. Yeah. So excellent presentation, sir. It was really very helpful. Many of our members had joined on this Zoom platform and YouTube. And this program will be also, the recorded program will also be there in our IMA KSB digital
Wonderful.
software, sir. So anyone, anytime, if they want to access, it is always there, sir.
Great.
So, yeah. So I want to thank our President IMA KSB, Dr. Lakkol, sir, for joining us in our IMA AMS webinar. Thank you, Lakkol, sir. I thank our immediate past President of IMA KSB, Dr. Kudwa, sir, for joining our program. Thank you, sir. I thank our today's excellent speaker, Dr. H.K. Nagaraj, sir, for the excellent and lucid presentation of the management of the renal calculi. We wholeheartedly thank you, sir, from IMA KSB and IMA AMS.
Very
Yeah.
good.
Okay,
Thank
ma'am.
you. Good
The
night.
chairperson of today's program, Dr. Prabhakar, sir, who has joined in spite of his busy schedule. We thank you, sir. I thank Dr. Rajshekhar Ballari, sir, our IMA past president and also IMA AMS past president, who had joined for our program. We thank you, sir. I thank our immediate IMA AMS chairman, Dr. Shivkumar Kumbar, sir, who had joined for our program. I thank all our office bearers of IMA AMS and KSB who had joined for our webinar. I thank all our IMA members, all the Southern Urology Society members, and all the postgraduates who had joined for our webinar. I thank each and everyone who had joined. Then I thank John, who had helped us in airing this program. I thank one and all.
Thank you. Good night.
Thank you.
We'll see all the